Good, thank you, Ramon. We've got a brief, but what I think is going to be a very interesting and certainly an important session. We have represented here 3 national leaders from 3 silos, or what used to be silos, stakeholders, let's call them, if you will. And these are 3 groups who in the past, have not played very well together in the same sandbox. But yet, getting you guys to play well together in the same sandbox, I think, is going to be critical if we're going to improve healthcare going forward into this century. And especially if we're working towards a patient-centered healthcare future. So with that in mind, just tell us who you are very quickly and where you're coming from, and then we'll get started. Go ahead. Michael?
Mike Dowling, I'm the president and CEO of Northwell.
That was brief. Okay.
Brief, yeah. I introduced myself a little bit this morning. So
okay.
Thank you.
Right. So Wolfgang Baiker, I'm the president and chief executive officer of Boehringer Ingelheim in the United States. I'm a physician by training, or at least I always say I used to be 30 plus years ago. And with that, at least I believe that we do have the patient in the center of what we're doing.
Good.
And I'm Broussard, the CEO of Humana.
Great, thank you, Bruce. So we're talking about this had been a sort of adversarial model. How do we break down those walls to make it a collaborative model instead of a competitive model here?
You want to start?
Yeah, let me just begin, and then obviously we'll go back and forth. Well, one goes back, I think, to what was discussed previously, including some of the things that were discussed by Tom Lee, is if we look at everything that we do, and we put the patient at the center, and we understand that from a patient point of view, they want you to deal with the question, not what's the matter with you, but they want to deal with the question we should be asking, what matters to you? Mm. And if you ask the patient, and again, I also think we've got to be thinking of ourselves as being in the service industry, and thinking of ourselves more in the customer service industry, not just the traditional patient industry, especially on the provider side. But if we ask the question, what matters to you, you get a very, very different response. What matters to you is how you manage the whole continuum of care, how you deal with the totality of health. Medical care delivery is a component of health, but not the same as health. Health involves, treating people when they get sick, but also preventing the illness and dealing and helping people stay healthy up front. This is often used and was used earlier today in discussions about the social determinants of health. So if you look at from the patient, the customer's patient point of view, if we look at it horizontally, and then we ask the question, each of us asks the question, how do we collaborate to deal with that horizontal need of the patient? Mm-hmm. It's a very different answer than you will get and if you ask about what is my industry or my component in the industry doing vertically with that patient. So rather than having the vertical look at the patient or the customer, you look at it horizontally. And if that's to occur, we're involved on the delivery side, you're involved on the pharma side, you're involved on the insurance side. So if we're to satisfy the customer, we have to be working together. One of the last points I'll make is that given all of the current discussion that's going on in healthcare these days and the possibilities of major government movement towards single payer, that if we don't figure out how to work together, somebody will tell us how to work together, and that answer will not be what it is we want. So if that happens, we are to blame because we haven't figured out how we collaborate to deal with the question, what matters to you.
You don't want government to impose that system on you. Right.
Not to the extent that some would like.
And maybe I'm not sure whether it was adversarial or adversarial. I think it was disconnected. I'll just give you why I think it's disconnected. If you look at in the pharmaceutical industry, we provide one of the products that are needed to restore or improve people's health, but we don't have that one customer. Yeah? So it's not one customer, for example, the patient. Mm-hmm. We have obviously the patient as the ultimate customer. We have the prescriber, the hospital, as the decision maker. and then we have the insurance company as the payer. So there is this, that's why I call it a disconnected system rather than adversarial. And I'm absolutely right, with you that say, if we don't get together, and what you say, somebody will tell us how to get together. But if we don't get together to make that one system rather than 3 disconnected systems, there are probably more players than the 3 of us. Right. Also from an industry perspective. But that is the only way that we can, first of all, maintain the great system that we have here in the United States when it comes to innovation, patient care, how we can improve the patient experience, and I'm convinced about that, probably also reduce total cost of healthcare so that the government gets what they actually want.
So, Bruce, you've, as the payer, has often been painted as the bad guy. And
so is us.
Well,
Depends on the day.
We'll get to you.
Well, I'm with, and if that's the case, I'm with 2 bad guys.
But you've often been at loggerheads then with the healthcare provider, the ultimate provider, the Michael Dowlings of the world, or his system. So what I haven't heard from you guys yet is how do we break down these old barriers? What do we do to actually get to collaboration? We're saying we want to do that, and you guys want to get it done, but you're only a piece of it. How do we break that down?
Let me just say a few things here. I do completely agree with Michael that the ultimate responsibility of all of us in healthcare is to improve the health and lifestyle of individuals. And when I think about health as an enabler for someone's life, it's not the end product. One of the challenges, there's a few challenges, and it gets back to this silo that Wolfgang was talking about, is that the economic model is paid to almost pit each other against one another.
It's set up to be adversarial.
It's set up that my cost is revenue, and the system's cost is the more individuals that's in Michael's hospital is the cost of the system. And so how do we align to the outcome that everyone's desiring that Michael just described, I think is the first thing. So aligned incentives around quality and cost is an important part of that. The second part, because we have had our own little silos like what Wolfgang has been talking about, the information flow is siloed. And so for Michael to see what's happening outside his institution is very difficult. And a part of that also is our measurements have been more oriented to volume versus quality aspects on payment. And so when I think about the barriers, one is around aligned incentives and continuing to work on the economic model. I'm very positive both within our organization, but nationwide we're seeing a much more adaptable healthcare system around value-based payment models. The second thing is interoperability of information. I think the flow of velocity of information. You look at what's happened to the financial systems or the financial industry since the founding of the ATM to today, and the ability for the convenience of the customer to be wherever in the world to be able to get cash, to the ability for you to see what your bank account looks like online, is all a result of that flow of information. And the ability to do that with insightful analytics that predict the outcome or predict the next best intervention. And then the third thing I would really say, and I'm excited about, is the integration of technology, the formation of APIs, the stacks that are being created by organizations, whether it's Microsoft, Google, or Humana, and the hospital systems are all, I think, going to create a more connected system. But we have to work on this ability for us as a organization to agree that no one's going to solve the problem. We're going to do it together, which requires trust.
So I hear some challenges in here, and one of them, as you were talking about in terms of data and information, aren't a lot of the systems going to consider that proprietary? This is our data, we can analyze it, benefit from it. Why should I share it with anybody else?
Well, a few things are happening, and you probably, we as an organization, and me specifically, are very oriented to it's not our data, it's the customer's data.
Okay.
And so whatever is housed in any one of our institutions, at the end of the day, was created by that patient and that patient data. And so what you see happening in regulation today, under a concept called Blue Button is not that it's trying to connect the system. It's trying to empower the individual to say, I'm going to allow this individual or this individual to have access to my information, as opposed to the institution. And I think that's a change in reference. It's a little bit what Michael's talking about. It's wrapped around the customer, and the customer decides it. It's no different than that mobile phone that you have in your pocket there, that the phone number you have is transferable.
Right, it's mine.
It's yours.
Right.
It's not the phone companies. That same idea in the systems today is that information is the information of the patient, and they should be giving the approval for it. And I'm very, very excited that the federal government is taking that on to force the industry to have interoperability that I ultimately think will create innovation.
Michael, we talked about this back at some conferences earlier in terms of this transparency of data, particularly as it relates to the patient. But what are the challenges, or can you identify the biggest challenge, if you will, here in making all of this happen?
At a very high level, I think it's the people have always considered, various companies have considered data their own proprietary use. It's theirs. I mean, we've had a big problem for years getting data from insurance companies. They'll have a lot more, they have a lot of longitudinal data about patients.
I haven't done a lot of work with Humana, so that,
and
I'll
we
exempt you from that.
we don't easily get it, yet people say, well, why didn't you have this, why don't you know this information? Well, we don't get the information because they have the information, they don't want to share it. Now, I believe that there's been a change occurring there. But let me just follow up on something. You talked a specific question about how can we work together. Let's imagine for the moment, and I'll deal with both companies that are next to me here. Let's say with a company like Humana that focuses primarily on Medicare and the elderly. We run programs for the elderly. They run programs for the elderly. Let's make this a hypothetical. What would happen if we decided, because this will all happen by us figuring out things together here, what would happen if we jointly ran programs together for the elderly in the community? Instead of having you running a program over here for the elderly, I'm running a program over here for the elderly. Now, you have to figure out how to pay me for the program that we run together, which is the second issue I'll raise. The other second area is we get into these big fights between us and payers about denials. 20% of the care that you will deliver in a hospital, which most people don't fully realize, are denied by the insurance company. We have a huge bureaucracy to try to get paid after the service is delivered. They have a big bureaucracy trying to prevent us from getting paid after we deliver the service. The patient is in the middle of it. They don't know what the heck is going on. And of course, we're responsible if something happens to the patient. The insurance company is not. If we were able to figure out a way to work together up front, so we reduce the denials and the confusion and remove the bureaucracy, reduce bureaucracy we have, they reduce the bureaucracy they have, very logical, can happen, should happen, and it must happen. On the pharmacy side, what would happen if we were to do a deal, for example, where we buy drugs, but we pay for the drug if we prove that the drug it works?
Right.
It's actually,
so
if I may, this is actually
and
something
you're probably doing it.
It's actually something that we're doing. So I believe BI is an industry leader, so we have the most what we call value-based contracts. I mean, in its simplest...
explain that to me.
Well, so
what you mean by
in its simplest form, it says, if a patient has disease X and you give a treatment, the treatment works, then we get paid. If it doesn't work, we don't get paid. Now that's the simplest way. It doesn't work in all diseases. So sometimes you have to look at patient populations to see that treatment with X compared to treatment with Y actually has a better outcome. For example, reduces hospitalizations, reduces certain additional complications, things like that. Keeps patients out of the hospital. They're healthier. They don't die. It keeps down the costs.
That's a good thing.
Now, it's a good thing. Now, unfortunately, there are systemic regulations in place that actually make this concept, which sounds so easy, not applicable in all situations. When you have Medicaid, you have best price. Now, if you have a value-based costing and you say, okay, it doesn't work in certain things, you don't get paid, your best price is 0. Now, that's not acceptable because you would then get 0 for those where it works. So these are hurdles that are not between us or between us. They're actually government hurdles that limit that applicability.
So there are regulatory challenges here.
Yeah, well, it's regulatory challenges and everything, but if you decide that you want to do something like this, and we do work together, I mean, our two companies work together pretty closely, as does Bruce's and ours. But what happened if we would just decided we were to do something like this and and then we together figured out how it is we, being able to modify the regulations, get around the regulations, or figure out another way to do it. If you stand back and you say, I can't do it because there is a regulation there, you will never do anything. Yeah. Because you'll have a regulation trying to regulate everything. But I can tell you, as I was on the regulator, I was in government for years, and I was one of the people doing some of the regulating. Sometimes when you're on that side of the fence, you're waiting for innovative people to come to you to suggest how you can do something very, very different. And I think that we have that opportunity to do that now. So, and once you start doing something like this, like I said, we were to do something on the drug world that we just talked, drug business we just talked about, you have no clue how it is that's going to emanate and change and modify into something else. Once you start small, it evolves. Because when you do something, you say to yourself, as you do it, oh boy, there's a different idea that I should be thinking about. And let's explore another avenue. And it blossoms from there. That's where innovation comes from. But it means, though, that we have to walk into it with an open mind and not constrained by our own thought process or constrained by our own business parameters that we typically get caught up into, and basically say, if you're trying to serve the public out there, how do we do it better? And I think that it will take a couple of companies, and some of this is happening already, a couple of companies to break through and say, this we are doing, and we're going to show the world that it can happen despite the difficulty that some people may assume exists, and then see what happens from there. That's how innovation occurs.
Yeah, I would just like to add a little bit what Michael was saying about this ability to reduce the bureaucratic processes, as wars that sort of have been created over the years. And as I mentioned at the beginning, these wars have been created as a result of a misalignment around the definition of what success is. I do think I see progress where a provider, whether it's a hospital system, physicians, and payers are working together to continue to align to a much more oriented to the outcome, the value-based payment models. That lessens the need, almost eliminates the need, because we're aligned together on the pre-auth, because we don't need it, because we're walking in the same direction. So what's good for an organization like mine is good for an organization economically for as Michael. The second thing it does also is it really frees these barriers of what's mine, what's yours kind of thing, to optimizing the care model and being able to share the information. And about 2/3 of our senior members, which represents the largest part of our population, is in relationships like that. And we find higher satisfaction with the provider, we find higher satisfaction with the customer, the member for our part, and patient for the provider side, and we also see better outcomes. And I think the more we can push to this ability to be aligned economically, the ability for the information then and the measurements to then be aligned to that economic interest, the better the outcomes become. Because right now, no matter what we say in this room, the economic incentives drive a lot of decision making, decision making. We all have our desire to improve the care, which we all really strive to, but at the end, it's that economic model that's always being measured.
So if all of this is going on kind of, let's say, behind the scenes, the majority of the general public has no idea that you guys are doing this somehow to make this better. And I see a need to bring them into the conversation, if you will, so at least they know that you guys are working together, because they're still going to think you're the payer, you're going to say no, hospital's looking to maximize, get as many patients in, and the drug companies just want to sell you expensive drugs. So how do we bring everybody else into this conversation so that, first of all, you know what they want and need as well, so it's not just you guys deciding, but so that they're part of that conversation.
We had a little pre-conversation. I made the comment that I, at the end of the day, they probably shouldn't know. There should be an easy, being personalized and simplified experience for them. But what we've seen in Medicare Advantage, which is a large and growing part of the Medicare business, that over the last 15 years, you've seen that group of beneficiaries move from a governmental-oriented product, Medicare fee-for-service, to a private offering a product, which is Medicare Advantage. And it's gone from about 15% of the Medicare beneficiaries to 35%. And what we hear back from them, and the reason why that's growing like that, is there's a few first, they get more for their dollars, so they get transportation, they get specialty coverage, they get social determinants assistance, they get the pharmacy benefit included in there. But more importantly, they work with providers like Michael and helping them get, when they get discharged from a hospital, to send 10 days worth of food home to them to help with their recovery. They have a company like Humana coming in and building rails in the bathroom to help them to prevent a fall, or building a ramp. They've just had a hip replacement. To me, that's where they see it. Right. And that's the experience. Us trying to explain it to them, I don't know if they should feel it and touch it a little bit to this patient-centric aspect of that versus then us having to explain it. And that's where it begins to say, wow, that's a really good opportunity. And I think Medicare Advantage is a great example of people voting with their feet.
Right. And there are other examples. And I was about to say they shouldn't know, they should experience it. And I mean, what we, for example, do is for certain indications that are really tough, we have what we call clinical educators. So we work, the clinical educators, work directly with the patients, help them through the treatment. We work very closely with the prescribers. And we also have people that help them, when they have challenges on getting reimbursed on their drugs. So they actually work with insurance companies, how to maneuver that. So I think that's what's relevant. Knowing for the general population, unfortunately, it's a complex topic. You can't package it into small sound bites, and it's so much easier to be adversarial, like many politicians do. Working, being collaborative is a lot more difficult to be explained.
Michael, because some of the programs that you talked about, and all three of you talked about, there's a risk involved. And there's a risk of some failure, which will involve some cost. So how do you manage that when somebody's saying to you, this is costing us money, we shouldn't be even trying this, or this might cost us some money? Manage risk, I guess.
Well, there's a risk to anything that you do that's new and different. And and if you don't fail ever so often, you'll never succeed. So the possibility that you might fail should never prevent you from trying something.
Learn more by failure.
Because what if Churchill said that success is going from failure to failure without a loss of enthusiasm. So I think let's take the social determinants of health piece, the wellness piece. Because we're involved with intake insurance companies. It's has been traditionally a transaction. They have the money.
We want it.
We want it. They want to keep it.
Oh, we want more
of it. Yeah. We'll after we figure it out, we'll give you what's left. But what would we have to change that from transaction to partnership. So we're dealing with an elderly population, let's say, and that's what Broussard works with. And we were to say, we want to keep in this community, this population healthy. How could we together develop a financial partnership for that particular community in that area where we have a mutual similar goal to keep that population healthy? If we looked at a partnership like that, we should easily be able to figure out how to develop the financial mechanisms between us to make that happen. And on the other side, on the illness side, is to figure out a way so that we agree up front what the goal is with regard to the care and the facilities. We agree up front about what criteria should be set in place with regard to any denials up front, or the prevention of denials up front, and you deal it in the back end. you do some of those things in a very productive way, you reduce a lot of the hassle for the person, for the customer at the end of the game, and they will see it and they'll notice it. But it requires us to actually move in that direction in a much more aggressive way. And you're not going to do this globally overall, quickly. You're going to do it through demonstrations. But you make your demonstrations very, very visible. You talk about them. You're open about it. You take, both sides take some risk. And it's not just financial risk. You have reputational risk and all of it.
Okay.
But if you're putting the patient at the center of everything, then I believe that at the end you cannot lose. If the patient wins, you can't lose. And I think that there are ways, but it will require us to completely change the way we work together. And we at Northwell, we're having discussions with a number of payers at the moment on that kind of a scenario. And I'm hoping over the next year or so that we will actually be able to make some headway to get both of us to figure out that we're in the same field and we've got to play the same game with the same purpose. Otherwise, we'll continue to fight, and if we continue to fight, we will both lose. And we both lose, guess who's going to lose the most? It's not about protecting us or protecting, Bruce's shop. It's about the people who will lose the most are the patients that we're about to serve. So it's incumbent upon us to figure this stuff out, and I think it can be done. It's the same on the pharma side. Right. I mean, and so adherence with regard to, drug use by patients. Now, we have the patients, you're connected with the patients. We want to make sure the patients keep their drugs together, or take their drugs at the appropriate time, etc., for whatever illness is that we're talking about. We together figure out how do we do that together.
Right.
How do we work with the technologies that exist out there that makes that actually easier to do than when you didn't have that technology? And we do that together. So you bite the apple a bite at a time. You don't take the whole thing, you take a piece at a time, and you make it very, very public. I think we can do this. And at least I know Northwell is interested in being unbelievably creative with like-minded partners to make this kind of thing happen.
And on the value side, if all the stakeholders are at the table together, particularly when you were talking about denials and what works and what doesn't, we've gotten better at figuring out which medications, which drugs work and which don't for a particular thing, instead of throwing everything at them. Yes. Likewise, you decide that, and I've seen a lot of this data, and some of that data is going to come from you, is what do we need to do a CAT scan and a PET scan on everybody, because that may or may not be actionable and change anything in terms of outcome, right? So it's all about, I hear you've got to be at the same, everybody's got to be at the table and working together.
And
collaboration.
Just using your CAT scan example, because it's a very perfect example, and but being able to share the CAT scan up and down the industry, so it doesn't need to be duplicated, and people are working off the same.
Right.
And today, the economic model in a number of areas and the information flow isn't set up to do that. And that's just a perfect example of why the inefficiencies and why the disagreement is that it's created there.
So we've got just about a minute left, and I always like at the end to ask each of our panelists, give me 30 seconds, I know that's tough, Michael, to the take-home message, a pearl of wisdom that they can take home and remember from this.
Have a big dose of optimism about what's possible.
I agree.
Optimism is good for your mental health anyway. It's good for organizational health. It helps with morale. It's an essential core ingredient of leadership. It opens up the doors for possibilities. Because if you look at it from the alternative, a pessimistic view, nothing seems bright. But if you wake up in the morning and things are bright, and you think good things can happen, good things happen. And I think in healthcare these days, that there is a need for a major, major dose of optimism. Because between now and the election in 2020, we're going to be hearing a constant flow of negativity and pessimism about what's wrong. Let's fix what's wrong, but let's understand what's right.
Just to build on that, and we were talking before, I have a high degree of optimism of the future. I think our science is continuing to improve, and the things we are doing today in genomics and other areas is just amazing to me, and the diseases that we are bringing great treatments to life. But I do think there's a convergence happening in healthcare that a decade from now we will see a different healthcare system and a better healthcare system where the three of us won't be talking about fighting, and I think we will always have our disagreements in some way or fashion, but I do think that you will see a much more integrated healthcare system as a result of a few things. I think payment model will continue to evolve in that. I think the flow of information will continue to get better. I think technology in the way to integrate it and make it much more personalized and simplified within, at the end of the day, the individual that's receiving the care, through analytics and the devices and all the things that are coming out, I think we're going to see that. And we've seen a ton of industries that have gone through this change. Healthcare has been slower, but there's some wedging that's going on, both regulatory and in addition, individuals like us on the stage, they're saying it needs to change, and let's be the brave ones to do it. So I have the same optimism that Michael has. It's going to be messy, it always is, and there's always going to be things thrown up, but I think we're on a verge of change here.
Nice.
And I'd say just one, I think that each one of us, that between us, we should, by this time next year, have done something different than we're doing today.
That'd be
If
nice.
we commit to that, we'll make it.
But wait, there's more. Wolfgang, you get final word.
Well, I'm an optimist myself. Yeah. So I mean, I'm in the as a physician you have to be optimistic. As a researcher you have to be optimistic. As a business person you have to be optimistic. I think you alluded to it. I mean, we live in a golden age of biology. I mean, what we can treat today already compared to even 5 or 10 years ago. Let's not talk about 100 years ago. What we will be able to treat in 3, 4, 5, 10 years from now will be mind-boggling. But also, in order to make that affordable and continue to have it affordable, I think that's why we need to work together. We need to change that paradigm, one step at a time. Yeah? Don't shoot for the high, whatever those grand ideas are, because it's not going to work. But we need to do something. Well, I know we're working together. We're working together. Maybe the three of us should get together and do something, between the three of us.
Well, let's commit.
Let's do it. All right. Thank you. I want to thank our panelists. Thank you all.
Thank you.